Thank you very much for the invitation, first of all. It's a great pleasure to be here. And it's also a great pleasure to give this presentation. So I'm struggling a little bit with the idea to have to show only 6 slides. So first of all, I have to say I can sign everything that Xavier has said. So that's absolutely what we're normally doing. So is it here? Yeah. So I think it worked. What are my main principles? There were the questions, and the first question is, should we remove the well-fixed femoral component? I would say I keep it in almost 100% of my cases. My feeling was it's a little bit more. Xavier has shown us examples, so malaligned cases, septic cases. As long as in an aseptic case, I try to keep it, but sometimes you have problems where you have to change it, and this is a specific case where I said, okay, we have to change this. On the other side, you see this on the left side, we have to revise this in some other cases. So it means, in general, we keep it. In some other cases, or in some rare cases, we have to revise it. These are cases where we revise it, but this is not the majority of our cases. In general, the number of aseptic loosening decreased significantly in Germany. We see more and more these rare cases. They were sent to us, and that's not the average. Revisions, so I was a little bit surprised. I expected we revise more cementless, but we analyzed the data for the last 2 years. Yes, we do 90% of cementless revisions, but we also do 10% cemented ones. This is a typical case where we go for a cementless revision, and that's for us, as long as the isthmus is still intact, we go for a cementless stem. Whenever the isthmus is disappeared, we start the discussion. So then we have sometimes the question, how stable will be a cementless stem? You see on the left side, this is a typical case where we go for a cemented revision. The osteopenic bone here, you have no clear cortical structure. That's cases for cemented revisions, and once again, these numbers decreased. The same on the cup side, whenever possible, we use these cemented systems. So there are really some rare indications that's normally really patients with weak bone, and in infected cases where we use in addition cement. The standard is a cementless revision. In cement, we think it is an excellent tool. As long as the cement is stable. We use it always with a knife blade. If the cement is really well connected to the bone, if this is the case, and if you have what is an older patient, you have a patient that has not these high expectations, and you know if you have to revise or you have to remove these well-fixed cement here, it means minimum perhaps needs 20 minutes, 30 minutes, 40 minutes, no idea. We try to keep it. What we also do is we check what is the problem, why such problems happen, and you cannot do always cement and cement. There are sometimes additional problems as seen here, and we use this as a cement and cement technique, but have stabilized this in addition with a plate. And I think the most important thing is with a medial buttress. In this case, we have used strut graft, but that makes really sense. Either we really like cement and within cement, and all the patients older than 80, it is normally a good alternative. Standard approaches we use in 75%, and you see much more than in endoclinic we use in ETO. As a standard means all the endofemoral approaches in ETO. In 25% of the cases, we not try to do the ETO as long as the implant is, because you have a lot of implants, they have the fixation area much more proximal, so sometimes it's enough only to open 2/3 of the stem or the stem length, not to open this. And the idea is we try to retain the isthmus. That's why we do this perhaps a little bit shorter than some of the colleagues said before, and not in all cases we do this in the long way. But the one and only thing that we always try to prevent is if there's a patient, and there are a lot of patients in Germany with a lateral approach, or what we call the transgluteal approach, or the hard-inch approach, we not recommend to use this approach again. Otherwise, we use the same approach as long as it is possible, but not never a transglutial approach again. The risk for limping afterwards is too big. Double mobility, it is 25%, so we are closer and closer to French, and it is increasing. So there is, meanwhile, this year we have, until from January to July, it is already 32%. We believe it is an excellent solution. Yes, we believe very strong in the non-modular situation, but you have sometimes situations where you need the modular one, as in this case, and then it makes sense, of course, to have this type of an implant. That's my presentation. Thank you very much. Only some cases to follow Xavier's recommendation.